Massive bony deficits occur with excised bone tumors, trauma, and revision arthroplasty. Megaprostheses have been developed to manage such deficits. There are several advantages, but their infection risk is high. Primary joint replacement has an infection risk of 1 to 2%, but the risk with megaprosthesis is 8 to 15% and over 40% in some cases. The objective of this study was to identify the rate of infection and to determine success rates in different megaprosthesis infection treatments. A systematic review of PubMed, Embase, and the Cochrane Library was conducted according to PRISMA guidelines. Titles and abstracts, and then full text were screened by 2 blinded independent reviewers. Data extracted included study characteristics, patient characteristics, and treatment and outcomes. Due to the heterogeneous nature of the data collected and the lack of prospective data, synthesis was performed through simple pooling. Overall quality of the evidence was assessed with the methodological index for non-randomized studies, aka Miner's approach. 16 studies were assessed to be eligible. Relevant studies are included in Table 1 in the middle of the poster. The majority of studies were Level 3 or 4, consisting of retrospective chart reviews or cohorts. The average Miner score was 11 out of 16. Pooled estimates of failure rates of patients undergoing debridement, antibiotics, and implant retention, aka DARE, was 55%. Failure rates of patients who underwent 1-stage revision was 47%. Failure rates of patients undergoing 2-stage revision was 28%. The failure rate for amputation was 2%, and the overall failure rate was 44%. This study is the first systematic review quantifying overall infection rate of megaprosthesis beyond just the tumor population. It demonstrates differences in infection eradication among the different surgical management options. Due to the heterogeneity of patients, high risk of bias, and variability in available data, comparative statistics were not performed. Overall, there is a lack of comparative data in the current literature to guide treatment options, and the quality of evidence is low and should be interpreted with caution.